Hey, good day. Hey, this is Dr. John McCormick. I'm here with Nick, and
how's it going?
second time around, trying out the co-host seat again. How's it feel over there?
Co-host. Oh, I've been promoted.
Promoted to co-host.
All right.
What do you think about that?
That sounds like a good deal to me.
That sounds good. You ready to wrap about reference-based pricing?
I'm ready to go. Let's get it.
Reference-based pricing is one of the tools in our toolbox that we use to make sure that our members are not overpaying for healthcare, right?
Exactly.
All right.
Exactly.
So, how successful you're on that side of the house. I'm not, right?
Yeah.
You're the ones that are reaching out to providers, trying to make great deals with the providers so they get paid a fair amount and the members aren't overpaying. How successful are you for doing that for our members?
Gosh, I'd say very successful. We have very minimal amount of challenges with providers when it comes to them accepting the reference-based pricing, Medicare rates, RBRBS.
So what is that? So sometimes we say things like Medicare prices and RBRES and but the regular run-of-the-mill folks out there, they don't know what that means, right? So we know that there's an evaluation done by the government, and they actually are surveying providers and looking at claims across providers and hospitals. And what they do is set a Medicare rate nationally, and it's actually adjusted by county, so it does account for places that are more expensive or places that are more expensive. And we can certainly debate if that's quote unquote fair and things like that, as far as does it actually pay the bills or not. A lot of evidence says it does. A lot of evidence says you need a little bit more to actually cover that differential because it's a lagging indicator.
Right.
So when you say when we do reference-based pricing, we're not saying we only will pay exactly what Medicare pays. So we pay more than that in some cases, right?
Yeah.
All right. So what do you think what do you normally land at? 130, 150, 170%? What does that look like for a routine kind of provider for us?
I'd say it's roughly between 120 and 150, if I'm not mistaken. I mean, for the ones that we have like a direct contract with, right?
Right.
Did I understand the question correct?
I think you did.
Okay.
I think you did. So
I'm
between
pretty
120 and 150, and really the difference between us and a lot of other plans is we may have reference-based priced them at 120 to 150, but we're also paying in cash at time of service.
Right, yeah.
So there's a
lot of times.
There's not this long lag of we're going to agree to this, but you still got to file a claim, and we're going to go back and forth on the claims 10 times, and then you're going to get paid.
We try to do it all before date of service
so
that we can get it all out of the way. The member doesn't have to worry about it after. They can get their thing done and out of sight, out of mind.
Cash and carry.
Cash is king.
Yeah, cash is king. But you say that, but ironically, there's some of these major hospital systems that they work with that tell us we can't take cash. Now we know that's BS, unfortunately. It's just that they don't want to take cash because they don't really want to reveal their cash rates.
Right. You want to keep it all secret. It's
why
very secretive.
Why, in your
it's
mind,
too secretive.
Would a hospital system resist reference-based pricing or cash-based pricing? What would prevent them from doing that?
What would prevent them from doing that, or why would they want? What would the motive be?
Yeah, what would their motive be?
It's to. They don't want the patients knowing, what they're paying for, because if they don't know, then who's to say that this knee orthoplasty isn't $60K here? Who's to say that? Who's to say that you don't owe a couple $100,000 for like a couple visits in the hospital? Who's to say? Who's to say? We can't. Nobody knows.
Nobody knows.
Nobody knows.
So by not doing reference-based pricing or refusing or resisting, let's say resisting strongly, cash rates and things like that, then what you end up with is this, I hate to say, this kind of double secret handshake agreement, generally with the major carriers, where you don't know what the actual cost is and you don't know what the other carriers are paying, and the other carriers don't know what the other carriers are paying, and worst of all, the person that's actually getting the service doesn't know what they're subscribing to when they walk through the door of that hospital. No. They don't know that they're paying 500 times the cost to get that service at that
Yeah.
location, that if they went 2 miles down the road, they would actually get a fast fare rate.
And man, I'm losing words. At a similar quality to what they would get at this major
Oftentimes
provider.
the same doctor.
Oftentimes the same doctor. That's a great point.
The same
There-
surgeon.
Oftentimes, so many authorizations we process are members that are trying to get this thing done, and the doctor's going at. Well, I guess we probably shouldn't mention any names of places. They're going to place A. Place A, not willing to do reference-based pricing, but the doctor also performs at place B.
Right.
But all it takes is, that extra step of being like, hey, are you willing to do it over at place B just for the sake of, the member, the patient,
Right.
the person who
I
actually
do it
needs
at
the
place
help?
A on Monday and Wednesday. I do it at place B on Thursday and Friday
Yeah.
every week.
Yeah.
So hey, member, would you have your third surgery or whatever on Thursday?
Mhm.
And let's save you and your employer and the plan, $40,000. What do you say?
Sounds good to me.
Because what
Sounds
happens,
great.
so we're seeing it so much this year, right? Rates going through the roof, 30, 40, 50% rate increases, and you got employers looking around going, why is my rates going up? And employees going, I can't afford that.
Mm-hmm.
And it's because you have, I hate to say, cabals of large medical groups, hospitals colluding with large medical plans that their business isn't about saving you money and delivering you high quality health care.
Yeah.
Their business is about making them money and delivering health care.
A lot of under the table. Follow the money.
Seems kind of shady, doesn't it?
Follow the money.
Yeah, follow the money. So, part of this conversation, because I saw an article today and kind of got me excited, I complain a lot about government and government intervention in healthcare and how they've messed it all up. And if you want healthcare to really, 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 really be messed up, trust a politician because they will mess it up trying to fix it. All right? They will ruin it trying to fix it. See, multiple examples from my other podcast. However, I saw an article today about Indiana building the ultimate reference-based pricing safe harbor. And I read through the article and I was like, wow, every state should do this. Every state. And they put teeth in it. They basically said, hospitals, you will take reference-based pricing. Here is the range in which we will allow you to charge. Totally transparent.
Yeah.
You can pick somewhere in this range. And if you don't do it, we're going to fine you $10,000 a day.
Seems completely reasonable to me.
Seems completely reasonable to me as a consumer.
Mm-hmm.
I want to know what I'm going to pay or my plan's going to pay because I know, although my copay or co-insurance or deductible may only be a set amount.
Right. That varies. That definitely varies.
It definitely varies.
Yeah.
If I don't work with my plan, then next year I may have the same copay and deductible, but my plan cost has just gone up. And if my plan cost goes up year after year after year after year, like we're seeing, what am I not getting? A raise. What are we not getting in the office? New equipment. All right? Because it becomes a choice for so many employers. We're either going to pay for health care or we're going to give people a raise.
Yeah.
So at the end of the day, it is money out of my pocket.
Yeah.
Above and beyond what it says on the plan document.
Right.
And so many people don't connect those dots.
And not to mention that the benefits go down year by year
Yeah,
as well.
and we know that
Not to
too.
mention,
We've seen
yeah.
deductibles go up, co-insurance go up, co-pays go up. So there's always an offset somewhere, right? But at the end of the day, it comes out of that employee's pocket.
Yeah.
They just don't, sometimes because there's delay in that transaction, they don't get it.
Somebody's got to pay for it.
They do.
Somebody's got to pay for it.
They do. So this is really cool. What we saw was metrics where some of these, I'm not talking about major hospital systems across the state of Indiana. I mean, setting rates at 125%, some 150%, some 180%,
really
some
reasonable.
190%. When you start thinking about that, you go, well, that's still, almost twice what somebody that's 65 and older will pay. That's not fair.
But
If I'm
that's-
65 and my knee surgery is $7,000, why is it if I'm 64 it's $14,000?
That's not taking into account though that a lot of the places before this mandate were probably charging upwards of 250, maybe 280%.
Or more.
Or more.
Or more.
Or more.
I
Yeah.
mean, we have a system just downtown. They're 600% of Medicare, and that's their bottom line.
600%.
All right?
No, that's a new one to me.
Yeah, 600%. All right?
Wow.
So and I like it to just go, well, they've got amazing marketing because obviously they keep people coming through their door, but that's just because people just don't understand. They don't understand. So let's wrap up on reference-based pricing. We think reference-based pricing certainly not the only tool you should have in your toolbox as a planner or an employer.
Yeah.
But I think it's fundamentally a fair way to do business.
Yeah.
All right, fair for the member, fair for the plan, fair for the employer, and ultimately it's fair for the provider in the hospital too, because I think as a provider of services, you should tell somebody how much something's going to cost in advance of providing those services. Even when I take my pet to the pet ER room, all right, when I walk through the door, they go, well, it's going to be $75 for us to see the dog. And then, based on what they see, like right there, they'll say, if we have to do this, it's going to be this for this. We're going to need an x-ray. That's another $100. We're
And they
going
break
to
it
have to
down
do
for
a
you.
shot. So they're estimating their bill,
Yeah.
your bill, while you're standing at the counter.
Right.
Or they'll take the dog back and come back out and say, this is what we can do, this is what it'll cost.
Yeah.
Wouldn't that be amazing if we could treat people as well as we treat our pets?
That would be great. That would be great.
It'd be pretty amazing.
It'd be pretty amazing.
Hey, that's all we're going to talk about today, reference-based pricing.
There you go.
Nick, welcome to the co-host chair.
And co-host.
All right.
Feels good to be here.
It's going to be great. We'll see you next time on the Pulse of Healthcare.
See you tomorrow. See you when I see you.
Couple weeks.